Hello, I am the director of the Korean Dental Hospital, Youngjae Kim. Today, I am not giving a lecture from the hospital, but from home. It's my first time giving a lecture from home, and I think I will occasionally conduct lectures from home in the future. And today's topic is implant occlusion. Last Saturday, I conducted a continuing education lecture for the Namyangju Dental Association under the topic of implant occlusion. We covered the differences in occlusion between natural teeth and implants, centric occlusion, and then eccentric occlusion, contact, and disclusion. We covered up to this point in the lecture and the maximum minimum law of occlusion, also known sometimes as the minimum maximum law. Regarding this, due to a lack of time in the current lecture, I mentioned that I would supplement it in this YouTube online lecture. So today, I will discuss the differences in occlusion between natural teeth and implants, and centric occlusion contact if possible, and next time about eccentric occlusion contact and disclusion. Next, I plan to discuss the law of minimum and maximum occlusion in about 4 sessions. The question of implant occlusion is a subject of interest to many dentists, because there are many dentists who are placing implants now, and while studying implants, they are very interested in placing implants themselves. But they have a lot of concerns because they don't really understand what to do after the implant prosthesis. So, they don't really understand natural tooth occlusion either. So how can they understand implant occlusion? Some think this way. And there are also those who simply say they don't know. And then there are people who say, what does it matter if it's high or low? What's the difference between natural teeth and implants? Even if you don't know well, some think it's fine if the implant's occlusion is lower compared to natural teeth, or that you should make the occlusion lower or reduce the occlusal surface area for safety. Most likely, most people think at this level and are actually practicing it. But it's a bit lacking, to be honest. So I've prepared this lecture today to talk about that. First, I will talk about implant occlusion. There is nothing particularly special about implant occlusion. The anatomical structure of natural teeth and implants have different biomechanical responses. Biomechanical? It is difficult to explain with a single word, but the anatomical structure is definitely different. Therefore, we think there will be differences in occlusion, and based on that, we derive the occlusal differences between natural teeth and implants. The most striking among these is that natural teeth are supported by the periodontal ligament. Of course, direct bone contact does not occur, but the periodontal ligament attaches to the root's cementum, and this cementum functions as a shock absorber. Due to the elasticity of the periodontal ligament, there is axial mobility of about 25 micrometer to 100 micrometer, and when lateral force is applied, the PDL periodontal ligament stretches and serves as a shock absorber. The periodontal ligament. On the other hand, as you can see in this photo, the implant makes direct contact with the bone tissue. We call this osseointegration. This is expressed as the bone attaching, but it is said that it does not actually attach. Most implants have a titanium surface. There are also HA coating methods and various manufacturing methods or surface treatments, but there is something called an inert material. When the titanium surface of an implant is exposed to air, it becomes coated with a TiO2 layer, known as an oxide film. Unlike stainless steel metal which rusts, it is surrounded by this oxide film. And this oxide film prevents any harmful effects on the bone tissue and human tissue. So in the end, the bone tissue regenerates right next to the oxide film. And if continuous force is exerted, the bone tissue around the implant becomes very tight. This is called intimate contact. As the bone regenerates in an almost voidless state, the bone becomes a structure that supports the implant. Thus, due to this structure and the difference in metal, most implants are made of titanium. Therefore, the properties of titanium are extremely important to us. Stainless, which does not rust, is an alloy of chrome and nickel. The alloy of chrome and nickel creates a chrome layer. So if implants are made from a chrome and nickel alloy, the chrome oxide layer coats the outer surface of the metal, preventing rust. This principle also applies to our drills. In implant surgery, even for drills that excavate bone, stainless steel is used. This is called sasfotanjet. They use the drill that doesn't rust because one reason it doesn't rust is that it's coated with a chrome oxide layer on the outside. However, when laser marking or machining is rough, this chrome oxide layer gets stripped away and it gets exposed. And if the chrome oxide layer does not form again, that area will rust. So if you look at the surgical drill for our implants, you can often see rusting from the laser marking area. In fact, almost all implant drills rust. By pondering this a bit more, you can understand why implants are made with titanium material. If you were to choose a material that doesn't rust other than titanium, eventually you might include an HA coating. In HA coating, hydroxyapatite does not rust because it's not metal. Therefore, HA-coated implants are also able to regenerate bone tissue very closely to the implant surface. Although it appears to be attached to our eyes, it is not actually attached. It is in intimate contact, and because this surface is treated and therefore rough in micron units, it appears uneven. This roughness makes it difficult to separate, and it looks as if it is adhered to the implant. However, it is not actually adhered. So intimate contact is like this. If there is moisture between the two sheets of glass, they cannot be separated. You cannot separate these two sheets of glass. So I think of it as the principle of surface tension. Therefore, it seems that the principle of surface tension is at work, allowing the implant to be continuously maintained within the bone tissue. So, when looking at most papers, the most promising material for implants is what is referred to as inert material, which does not rust. It's not affected by rust, so inert material is highly recommended. In the past, attempts were made with aluminum, then silver, and implants were made using various metals. But recently it has almost universally moved to titanium, and implants with HA coating on titanium are now predominantly used. Also, most are made from pure titanium, and HA-coated implants are sold as secondary. Thus, the most important thing for us is inert material, and it must not rust. Rust eventually emits harmful substances to the bony tissue. Therefore, almost every time the use of inert material it seems a conclusion has been reached. In the past, there were also sapphire implants. And what do you call it? Silica? Is it SiO2? Such materials also existed. It's a material that does not rust. So when such a material is inserted into the bone regenerates close to the surface of the implant. And on this implant surface, here is TO2. Since there is a TO2 layer, it does not release harmful substances to the bone. The foundation for implants to continue to exist in the oral cavity has been established. Recently, pure titanium has been noted to break easily, so it's called grade 5 Eli. It's referred to as 64 alloy. It contains 6% aluminum and then vanadium. Beryllium? Whether it's beryllium or vanadium, at any rate, we're using an alloy that contains about 4%, but aluminum is prone to rust. And vanadium is probably classified as a carcinogen. So it seems like there are not many companies making implants with 64 alloys anymore. Additionally, in the case of the United States, when a fixture breaks or tears, it seems to become an issue. Therefore, perhaps American products still have some 64 alloy left, and it seems that almost all European products are manufactured with pure titanium. Thus, it seems like implant fixtures are being manufactured with pure titanium. And the superstructure is ultimately the implant abutment. Because the abutment made of pure titanium is somewhat weak, it seems that the regulations have been almost unified with the 64 alloy. They don't do HA coating, and almost every implant company uses 64 alloy. So they are making almost all prosthetic elements, like the upper abutment with titanium grade 5. So it's a bit funny. Almost everyone uses titanium, and the upper part is standardized with 64 alloy, which is difficult. The upper part uses 64 alloy, and I think it also affects the ilic. So there are quite a few people who see it as somewhat problematic in terms of biocompatibility. So how this will be resolved is unclear. The implant abutment keeps breaking and the screw keeps breaking, so Almost all companies. You want to use a material with higher strength. However, using a material with higher strength does not mean the screw won't loosen. It seems that because the screw often loosens, many dental directors as well as patients are experiencing discomfort. That's one thing. As a result, the fixture surface and the bone tissue make intimate contact. So when occlusal force is applied, that occlusal force is transmitted to the fixture through the abutment. The fixture transmits occlusal loads to the adjacent bone tissue, which absorbs the occlusal load. Therefore, the elasticity occurring in the periodontal ligament is about 25 micrometer to 100 micrometer. But since the implant does not have a periodontal ligament, the axial displacement is reported to be approximately 3 micrometer to 5 micrometer, and the lateral side is measured to be probably around 8 micrometer. Therefore, according to the papers, if occlusal force is applied and overload occurs, the periodontal ligament widens or is stretched. How should I put it? The periodontal ligament serves as a stress absorber in the end. Since the implant does not have this function, crestal bone loss occurs immediately. And once this starts to dissolve, it goes down continuously. Eventually, the implant undergoes a process of loosening. And when stress is applied, the screw loosens and ultimately abutments or fixtures often break. If you consider the reason, it's because the support is too rigid. So there is no role for stress breaking, which sometimes results in stress concentrating at the connection areas between the screw, abutment, and fixture. There used to be an implant called IME implant. In the case of the IME implant, it added a plastic component that could absorb shock, functioning as a shock absorber. This component absorbed the stress coming from occlusal forces. This innovation once gained sensational popularity. When I was in the military, around 1992, at that time this product was tremendous. You usually only know about brainmark implants. But before that, there were also cylinder types, HA coatings, and HA coatings with EMI in cylinder types. It's called an EMI component. The idea is to insert a hard plastic-like component in between to absorb occlusal forces. It appealed to dentists. Logically, it is exactly correct. However, the reason this product did not last long is that the parts kept breaking down every 3 to 6 months. So patients had to be called in every 3 to 6 months to replace the parts. The bigger problem was that despite this, crestal bone loss or surrounding inflammation occurred. So this product vanished into history and no longer exists. It seems like they didn't do such things anymore. This product came out when I was in the military, so I wanted to go to Germany to learn this, but at that time, soldiers were not allowed to go abroad, so I still remember feeling a bit regretful. So I remember it. It's called a schematic diagram, right? If you draw a diagram, the ultimate difference is the presence or absence of the periodontal ligament. It comes down to whether this periodontal ligament is present or not, and I believe the rest falls under the realm of periodontology. The second point is that when you think about it, implants are in direct contact with the bone tissue, so ultimately the property to resist occlusal force is determined by the thickness of this bone, but most crestal bones are thin. Since they're thin, it seems like the bone collapses quickly when overloaded. In the case of natural teeth, this crestal bone receives blood supplied through the periodontal ligament, and from both perspectives, the bone around the implant doesn't have a periodontal ligament, so ultimately it's directly exposed to occlusal loading as well as receiving limited blood supply. Therefore, ultimately, maintaining implants generally becomes somewhat disadvantageous, and crestal bone loss seems to occur quickly and easily. I think this is something that needs some consideration. We call this the implant occlusal scheme. Such terms are not used much these days, but when we were in school, we used them quite a bit. Nowadays, protocol, implant occlusal, occlusion protocol, occlusal protocol, I'm not sure. A scheme is something that summarizes a concept. It's a summary that tells us how to proceed, and eventually, it has become necessary to follow these suggestions. Thus, if possible, when eccentric occlusion. Ensure as many occlusal contacts as possible are made simultaneously and evenly. This is what is said. Next, there is the concept of the all-square concept. I will discuss this when talking about centric occlusion and implant occlusion later. It's written about under-occlusion, discussing buccalized or lingualized occlusion. I am quite familiar with lingualized occlusion, but buccalized occlusion is a bit challenging to understand. I will also explain this in detail when discussing centric occlusion. Next, the occlusal surface should be reduced. Narrow table. And then, allow the occlusal force to move axially towards the center and reduce the non-axial force. This is the protocol. So it would be good to understand this protocol well. Next, eccentric tooth contact is being referred to as sequential guidance. I will talk more about this in eccentric occlusion, and essentially it's about reducing cuspal inclination. This will help reduce lateral pressure. Since lateral pressure bends the implant, this bending force needs to be reduced, and the occlusal load should be directed more axially towards the center. Of course, this is the proper guideline. Next, the night guard. Using a night guard when there is parafunction. So when a patient with bruxism comes in, I also discuss an occlusal splint. The reason is that if not addressed, from the patient's perspective, if bruxism occurs, not only is the natural tooth damaged, but I believe the implant will not last long either. And single units are simple, really. They are occluded slightly lower than the adjacent teeth. The occlusion is formed. I think this way, normal tooth shape must be restored to enable aesthetic prosthetic restoration. And you increase the proximal contact slightly more towards the surface. Because there's the issue of food packing, and since it's a single, it absorbs rotational force. While connecting 2 or 3 with a bridge has the advantage of not absorbing rotational force, when dealing with a single unit, any lateral forces that occur on the occlusal table will eventually cause the abutment to rotate. Then the screw comes loose immediately. So what I experienced was, back when I used to do a lot of screw-type implants, in such cases, a second molar implant, especially when a mandibular second molar implant was placed, screw loosening occurred quite frequently. There was someone who visited me for about 10 years and eventually left disappointed. As I recall, I used a 3i implant, and if I think a little more about such cases, having the proximal contact surface between the first molar in the front and the second molar implant prosthesis that I applied the implant to may reduce loosening. However, since there is no choice but for the overload to be relieved, that was a bit disappointing for me. Looking back after experiencing such events, I realized that we used a lot of screw-retained implants back then. It seems we preferred surface contact whenever possible. Of course, textbooks recommend point contact, but in fact, as one ages, point contact almost disappears, and surface contact becomes more prevalent. Therefore, if surface contact is restored well, food packing decreases, and screw loosening is also prevented. However, there are quite many cases where screw-retained ones are unavoidable. How to handle multiple unit implant prostheses and how to deal with occlusion. It is divided into anterior and posterior. And this is a slightly difficult topic, because theoretically, it is suggested not to make contact, but with further study, one learns that molars should contact and anteriors should have a space of about 30 micrometer. So the idea is to create a separation of about 30 micrometer. When you consider where this logic originated, it becomes somewhat ambiguous. So, the posterior natural tooth sinks. When occlusal force is applied, as I mentioned earlier, the sinking is about 25 micrometer to 100 micrometer. If you think about it, when the natural teeth are above and below, the micromobility is about 50 micrometer to 200 micrometer. After the posterior teeth have sunk and the anterior teeth make contact, what happens to these anterior teeth? If contact continues, they loosen. Therefore, in the posterior area, the fundamental principle is to offset the amount of sinking mathematically when occlusal load is applied and to elevate the anterior teeth. However, the 30 micrometer mentioned here is based on very healthy individuals. This refers to those with minimal molar sinking, and in reality, if the periodontal ligament has widened or the patient has periodontal disease to some extent, the movement can be 0.1 millimeter. In that case, you need to raise it by 0.1 millimeter. Otherwise, all the teeth will flare forward. The basic principle is to compensate for the sinking of the molars to lift the anterior teeth. Then, natural teeth and implants must also be lifted accordingly. It needs to be lifted, but there is something a bit complicated here. Because when it comes to lateral excursion, you can't lift it, right? When natural teeth and implants coexist during lateral excursion, the natural teeth eventually move due to horizontal pressure. If you think about it, only the immobile implant is exposed to lateral excursion and an overload is applied. So it may feel a bit difficult because that issue also needs to be addressed. Therefore, during excursion, since the natural teeth move due to occlusal force, it must be evenly matched there. What I'm saying is that even contact is necessary. So I think the protocol is to align them evenly at the same time. Therefore, I perform anterior implants with these theories in mind. As a result, I think I was able to maintain a good relationship with my patients. If you look here, it says horizontal and vertical overlap. And it is said to reduce the lateral force in protrusive guidance. Here, what horizontal and vertical overlap mean are overbite and overjet, respectively. Implants for patients with overbite and deep anterior teeth are very difficult. So, it would be good to calculate these well and reduce the overlap when there are multiple anterior teeth. For example, consider that this right central incisor is an implant and the left central incisor is a natural tooth. Another funny thing is that controlling overbite and overjet was mentioned. Overbite should be reduced and overjet should be increased to reduce overlap. However, if only one implant is different in shape when there is a natural tooth, it is not aesthetic. So it seems to be a somewhat inconsistent situation. Therefore, when it's a full mouth or there are multiple implants, this is correct. I also think it is possible to intentionally adjust natural teeth to control the overall overbite and overjet. Otherwise, when only a single crown is used, it becomes an illogical situation. In my experience, we have reviewed these points together. Next, to create good biomechanical conditions for the implant abutment, it is suggested to form the excursive guidance well, but this is somewhat ambiguous. If we follow this idea, the posterior is the issue. The posterior is the problem. But in the case of the posterior teeth, they eventually protect the entire area. In centric relation, the maximum intercuspation and relief occurs only in the posterior, leaving the anterior teeth in a non-contact state. Therefore, in maximum intercuspation and centric relation, the occlusion of the posterior teeth protects the anteriors, and when moving to an excursive position, anterior guidance occurs in the anterior teeth, allowing the posterior teeth to disclude. Thus, in the excursive position, the anterior teeth end up protecting the posterior teeth, creating a mutually protected occlusion state. Therefore, it is expressed like this. It doesn't seem to be canine protected, but rather mutually, meaning the anterior protects the posterior and the posterior protects the anterior. In centric occlusion, the posterior teeth protect the anterior teeth, and in eccentric occlusion, the anterior teeth protect the posterior teeth, forming this style of occlusion. Anyway, if canines are present, canine guidance is naturally applied. If canines are absent or restored prosthetically, it's burdensome for the canines to endure excessive occlusal force. There was a time when the Korean Dental Association conducted a survey, and it showed that if the prosthesis includes the canine, the cement dissolves within 4 to 5 years, or if multiple are done, problems arise, according to the published data I saw. That was about 20 years ago, and back then, it was thought that an occlusion wasn't valid without canine guidance. Many people believed that if it wasn't gnathology, it was quackery. Of course, nowadays, gnathology has faded, and there aren't many who strongly advocate for it, but it was quite significant at that time. In order to learn about occlusion, one had to study gnathology. As a result, almost everyone performed canine guidance, creating canine premature contacts. I think that's ultimately why such issues occurred. Recently, there's been a step back, considering restoring the canine or, if the canine is absent, opting for group function. And next, they recommend appropriately supporting the abutment for working guidance, but I'm not sure. What exactly is appropriate? Since what is optimum is not certain, most protocols currently involve under-occlusion. In other words, we aim to achieve under-occlusion. We want to induce a minimal underbite on the implant side. It's like this. What happens if the other party knows all the secrets when performing magic? It turns into comedy rather than magic. Magic is about making the audience feel wonder without knowing the secrets. Similarly, when performing under-occlusion, the patient should not be aware of the underbite. Therefore, the extent of the underbite should be such that the shim stock barely slips out. There are shim stocks ranging from 8 micrometer to 30 micrometer, explained as light contact. In maximum intercuspation, it should be to the point where it barely slips out. And when the shim stock is removed, it should create a slight scratch as it comes out. However, the problem is that if it touches at even one point, the shim stock does not slip out. According to nathology, in posterior occlusion, the mandibular first molar should contact at 12 to 13 points. However, in this situation, even if it touches at one point, the shim stock will not slip out, so I am not sure about this. At one time it was extremely popular. Therefore, every director checked the shim stock, and it seems they are still doing so. When talking with our hospital staff, they say that they still hear about this practice being done elsewhere recently. That's why there is talk of continuously purchasing shim stock. There is no need for that. If you stamp it on occlusion paper, the degree of occlusion comes out accurately. What about high spots? Called a bullseye, the center is punctured so that there is no occlusion mark, and the surrounding area appears red. Around high spots, it appears in red or blue. Anyway, what shows up on the occlusion paper is called a bullseye. This term also actually came from the US and abroad. Since the field of dentistry itself originated from abroad, many terms are in English. Anyway, when you take an impression using the articulation paper, the number of contact points also comes out. Next, you need to observe the intensity with which the occlusal points are being marked, and then compare them across the entire set. This will help determine whether the occlusal points on the implant are high or low, how the occlusion on the natural teeth is, and whether it is a point contact or surface contact for the natural teeth. Additionally, it's important to distinguish whether the implant occlusion I performed is a point contact or surface contact. Without a strategic and qualitative evaluation, it remains impossible to know forever. One should not rely solely on one-dimensional thinking, such as high or low. You cannot discuss implant occlusion with simple judgments of high, low, or the same. So take the bite registration accurately, strategically analyze and carefully examine the nature of how it was captured, and by comparing them, you can understand what treatment I provided and how the patient feels. If you continue to hypothesize about the reaction of such occlusion from the data, you may realize some things yourself, or the patient may give some signs or responses. When you talk to the patient, you can find out whether it was strong or weak. Patients are also diverse. There are people who are okay with a high level, those who cannot stand it even if it's slightly high, those who can quickly notice even a slight decrease, and those who are fine even when it's low. There is not just one correct answer. Because various situations exist, the only way is to take an impression of the occlusion paper for strategic and qualitative analysis, while also observing the patient's response. We cannot claim that there is an absolute correct answer. It also differs when the patient bites lightly compared to when he bites firmly. It seems that making it as similar as possible to natural teeth makes patients feel more comfortable. Therefore, when looking at the occlusion paper, one should not just capture the implants and prosthetics that he has done, but also examine the remaining teeth, opposing teeth, and even observe the occlusion points on the opposite side as a whole. And it is necessary to conduct a strategic qualitative comparison analysis. Simply talking about whether the shim stock slips or not is of course easier to understand. However, if you think in that manner, it becomes a multiple choice problem. There are only two answers. A question with only two possible answers is called a yes-no question. These questions are the easiest to understand. However, such simple questions cannot explain phenomena. But because everything is evaluated just by observing whether this shim stock slips, I feel a bit frustrated. Anyway, in this way, when checking the guidance by using the right and left sides, there were many cases where one side slipped and the other did not. The working side does not slip, and the balancing side sometimes does. Among implant patients, there are very few with normal occlusion. There are many cases of balancing side premature contacts. But as an example, let's say the tooth with a premature contact on the balancing side is missing, leading to an implant. The working side is weak. In such a situation, regardless of the method used, a balancing side premature contact will occur. A balancing guide forms, but I can't tell if it's a guide or a premature contact. However, if you decide to grind it down to clear it, you won't be able to achieve centric occlusion. Since the centric occlusion point cannot be established, if you grind it, it becomes under. And if it becomes under, the request is made to do it again, and grinding it again makes it under once more, leading to a seesaw situation going back and forth. Eventually, both the patient and we become exhausted. I have had many experiences where the problem was not resolved. In conclusion, it is impossible to simply evaluate whether the shim stock slips or not. and we need to see the overall occlusion situation by taking an occlusal record. The same applies to lateral movements. All guides should be done. After strategically and qualitatively analyzing the occlusal records, the occlusion of natural teeth and implants must be assessed. Let's look at the patient's photographs together. I understand that this patient had his implant done on Jeju Island. His residence is near my dental office. So he works on Jeju Island while his family resides near my office, and it seems he visits once in a while on weekends or 1 to 2 times a month. When this patient visited, he said his teeth were very uncomfortable. He mentioned they were sensitive, and this area might be referred to as abtraction. This all comes off, and the incisors are the same. It's precarious. Everything has come off here too. However, an implant has been placed. If you look at the implant, it was made under occlusion. But here, it has a lot of contact. Right? On the maxilla, on the right side, it's the first molar, and occlusal adjustment was performed. It seems like it was done by a doctor with slightly less prosthetic skill. During the occlusal adjustment, they carved out this area. They just carved it out deeply. It was just carved deeply, nothing else. It was carved out deeply. So when this becomes under occlusion, what happens? The premolars became over-occluded. As a result, abfractions have formed everywhere, leading to an unmanageable situation. By making the left molars under occlusion compared to the right side, the premolars are under a heavy occlusal load. The right side is relatively better. This is also an implant. The even occlusion has been adjusted. The patient talks about various symptoms, such as sensitivity in this natural tooth and some response to thermal stimuli. However, there are not many treatments I can offer. So, I suggest to the patient that we try adjusting this area again, and I think this tooth was extracted and replaced with an implant. I believe they used an implant called SS2 from Company O here. So, this seems good, but in my opinion, it doesn't have much difference from other implants. Anyhow, this is what happened. Since it's tissue level, it's slightly away from connection issues, but because mobility increased and it hurts, it's an over-occlusion. Ultimately, an implant is necessary. What should we do? Occlusion. We will probably do it like this. We will go for an even occlusion. Only then, the natural teeth and the implant share occlusal force. Of course, this side will quickly end up in a similar situation. If you look here, it looks as if it's all broken, and the anterior teeth are strong. You can see the occlusal marks on the anterior teeth like this. They appear here, and they appear here. The red ones are centric occlusal points, and the blue ones are eccentric occlusal points. As you can see here, they all appear, because the vertical point of the molars has lowered. This is due to tooth wear. Holding cusp. The lingual side has all lowered. As the jaw moves backward, the bite becomes deeper. You can see a little bit of red here. Eventually, as the vertical point lowers, the anterior teeth start to touch. The anterior teeth flare and become overloaded, so they seem to be continuously deteriorating. In my case, I see a lot of patients like this. When they come, how should we resolve it? Piece by piece as you proceed, it results in a full mouth placement, with all 28 implants inserted. Therefore, of course, implants are placed in these 2 areas. Here we do 2 as well. You can skip 1 by removing 3, but there's no real need to do so. So you can just think of it as 1 per tooth, but most people are intimidated by that. That's why I'm thinking like this. There are things learned and things still in doubt. I have a new question. In this process, the question is, when it comes to a canine implant, should we aim for canine guidance? Earlier we mentioned doing group function. In fact, if the implant is sturdy, or if the connection is very solid, aiming for canine guidance isn't a bad idea. Because if one side has canine guidance, the opposite side also achieves canine guidance. It holds true for both sides. However, if you're doing a canine guidance implant on one side, and the canine responsible for guidance is missing, the implant is placed, then you must provide a prosthetic for canine guidance to maintain symmetry. If you don't aim for canine guidance, the symmetry is off. So, we need to carefully consider how we should accept such things. Then the situation becomes one where the implant is overloaded. However, if the bone structure is healthy, it is important to use the largest possible size implant and a strong connection to create canine guidance regardless of the circumstances. This is because creating conditions that can withstand lateral pressure results in canine guidance, and if smaller implants are used, or if the robustness of the connection is lacking, meaning there is mechanical stress or poor fitting, that is, a lack of precision, then these situations arise. When canine guidance is applied, eventually issues will arise with the implant. Therefore, in such cases, methods like group function are used to align the height similar to adjacent teeth. This ensures that the canine does not only touch the canine to cause overload. However, whether that is the correct method is uncertain. In my case, when applying canine guidance, if the tooth responsible for canine guidance is lost, I sometimes place a fixture with a length of 13 mm for a canine guidance implant, and at other times, I have placed a fixture with a diameter of 6.2 mm. Anyway, if there is bone, I try to implant the thickest and longest possible. And next, I choose an implant type with a strong connection, such as locking taper or Torex. When the prosthetic restoration is done, canine guidance is applied. Otherwise, if a regular implant is used, it would probably be done with group function. Another issue is, as mentioned earlier, the anterior implant discussion. All the adjacent teeth are moving, so what happens when the anterior guidance allows the incisors to touch? Only the implant makes contact while the rest moves. Therefore, it was impossible to create anterior guidance. This situation was quite common. If the adjacent teeth move, first guide the adjacent teeth to move, and then make the implant make contact. I have also done it this way. In certain instances, adjacent anterior teeth with poor periodontal condition have been treated by means of a crown bridge to reduce or stabilize mobility prior to proceeding with the implant. If the prognosis seems poor, additional extraction is recommended. Tell the patient the tooth next to it is too loose, so this implant might be the only one to keep contacting. And if he agrees, bind 2 or 3 more to allow the implant to handle anterior guidance. Let's examine the content with this concept in mind. Upon consideration, in centric relation earlier, the centric occlusion of the molars protected the anterior, and in eccentric relation, the guidance of the anterior teeth elevated the molars. By inducing disclusion, a mutually protective occlusion is established. This is how it was expressed, and to explain it goes like this. If natural teeth are in good condition, in fact implants can be slightly underused. They can make less contact. If the occlusal support of natural teeth is good, natural teeth protect the implants. Also, if there are many natural teeth, implants can be made to contact slightly less than the natural teeth. So, the occlusion is set up to allow natural teeth to protect the implants, and conversely, in situations where there are many implants, or the support of the implant is good, occlusion is formed primarily around the implants. This allows natural teeth to slightly avoid contact. When occlusal force is applied, the periodontal ligament acts as a shock absorber and deforms. This protocol is set to form a mutually protected occlusion where implants can protect natural teeth. So, if the condition of the natural teeth is not good, I persuade the patient. I ask if they would consider getting a few more implants. Some patients respond like this. Some bring up the concept that having 20 teeth ensures living sufficiently until 80 years old, while others think that absolutely preserving natural teeth is imperative and that extracting any tooth with even a slight chance of preservation is unqualified for a dentist. However, you must see the whole picture. If you continue to neglect movable natural teeth, you start chewing with the immovable natural teeth. This leads to a situation where those natural teeth cannot last long and collapse together, leading to mutual destruction. But by placing implants and supporting occlusion with prosthetics, natural teeth can rely on implants. It becomes a mutually protective occlusion form. Then the remaining natural teeth will last longer. Therefore, you need to think about the whole picture. If you solely focus on preserving natural teeth, the adjacent healthy natural teeth will also end up falling out. This has been a problem. And because of such protocols, when placing posterior implants, make them slightly in contact. But what should we do if all the molars are restored with implants? Implants alone cannot be made to have slight contact. The same goes for when full mouth rehabilitation is done. When all teeth are lost, and the full arch implant reconstruction is performed, how should we design the occlusion? Even if the opposing teeth are dentures, a fully balanced occlusion should be achieved. Because if you think about dentures, the skill is making sure the dentures don't wobble no matter where you bite. A fully balanced occlusion is recommended. So what I experienced was a protocol previously developed by Company I. That was over 20 years ago. It was a time when canine guidance was highly popular. It's been about 25 years. At that time, the head of the training center from Company I visited the hospital. So we talked, and it turned out he was Italian. And it seemed his father was Italian, and his mother was probably German. When he showed us at that time, he was also doing dentures with canine guidance. I'm not sure how it has been maintained, but perhaps the canine guidance theory is the only surviving one because occlusion theories have been repeatedly applied. That's how it happened. But in fact, Company I was the first to develop the Gothic arch system while developing a denture system, and it seems they received a lot of support from a prosthodontics department at a university in Switzerland. So what they designed was not canine guidance. They called it physiologic occlusion, and it was tailored to each patient. Next, the dentures were made with fully balanced occlusion, but the concept of physiologic occlusion has almost disappeared. I was surprised because it seemed like only canine guidance remained, and the denture was trying to do canine guidance as well. However, that didn't last long and eventually disappeared. It seems to have returned to its original state. Even now, there seem to be very few people who want to do dentures with canine guidance. If someone insists on it, I would question their ability. I apologize. It's a bit of an extreme expression, but it will lead to conflicts with patients. The patient will keep coming back saying the denture is falling out, and if the dentist continues to insist on canine guidance, from the patient's perspective, that director might have some academic stature, but I can't help but think that you don't consider my pain, my discomfort. So I don't think insisting on canine guidance is appropriate. And cases like implant overdenture are also difficult. I once attended a symposium on ITI implants. There, an economist was brought in to talk about the implant industry. And, in the past there was something like that, agriculture. He talked about the transition from an agricultural country to an industrial country, and ITI implants stated that they develop implants for about 10 years and conduct clinical trials for another 10 years before starting sales. In our country, the development was fast because implants were copied, but ITI implants think that the industry becomes corrupted when products start being copied abroad. He also talked a lot about the results of overdentures. At that time, implants were very expensive, and there weren't many people who used them. Overdentures are typically done with either 2 or 4 implants. In most cases, 2 implants were used. In my memory, the 5-year success rate for 2 implants was around 82%, or 80%, whereas the 5-year success rate for 4 implants was close to 90%. However, in the case of anterior guidance occlusion, implants are usually placed in the mandibular anterior teeth. In that case, they do not last long. So the question is whether to use canine guidance even when doing implant overdentures. It's hard to imagine, isn't it? But you are doing it that way, almost everyone. I can't understand that. When canine guidance is applied, you usually use a Dalbo attachment or an attachment. Then an O-ring is fitted there, right? So what happens? The O-ring is made of rubber material. So after 6 months, it gets torn and worn out, and eventually it has to be replaced. It must be replaced every 6 months. And it is a bit disheartening to see the bone around the implant resorb. Since such things are happening quite frequently, we start to question why we do canine guidance and anterior guidance when we perform implant overdentures. Should we not do fully balanced occlusion? That's the type of question that arises. The study of occlusion begins with these questions. It is not something you start knowing the answers to. This is true for all kinds of study. You study because you don't know, and you realize things because you study. As you practice, you start to understand, this is how it is. I often say there is a difference between knowledge and realization. Experience and wisdom are completely different things. We can acquire knowledge from reading books. However, not all of it is correct, so at some point you come to understand this. As you continue, you find that about 90% of the papers become meaningless and around 5% become enduring knowledge. Even what's written in books doesn't always go by the book. Ultimately, you come to know by directly practicing. This approach might not be quite right. Doing it this way might work better. You come to realize these things. You will realize. So in the end, wisdom is acquired, rather than knowledge. Doing implant overdenture is not difficult. Only 2 or 4 implants were placed in the anterior teeth, and then attach the attachment and proceed with the overdenture. The occlusion is difficult. Occlusion is very difficult. So this was an important point from my perspective. As I was considering these things, I began to think about how best to approach it. And I realized that this problem could be solved through mathematical research. And this concern has been repeated. So it seems that we've found more ways. Many patients with these types of cases come to us. It is a situation that must be resolved somehow, right? Where the problem started, we need to know how to correct it. If you look here like this, periimplantitis has occurred. Is there a problem with the implant here then? Consider it carefully. Is this a problem of the surface? Or what is the problem? Is the size small? It's not small in size. The situation. If you look, the occlusal plane it protruded like this. Why did it become like this? It is a bit difficult to understand immediately. In my opinion, the timing of the implant surgery might have been different. The maxillary teeth have risen. After leaving the extrusion untreated and performing implant treatment, an occlusal curve step developed following the extraction of the opposite tooth and subsequent implant treatment. And as you can see, elsewhere it's natural teeth versus implants, implant versus natural tooth. So, this side can be considered as the natural tooth yielding when occlusal force is applied, isn't it? However, this side cannot avoid each other. This is because it moves around 3 micrometer to 5 micrometer. In the case of natural teeth, I think they will move more than 100 micrometer here. Of course, since everything is bundled, I don't know what will happen, but here it will move 3 micrometer, 5 micrometer, and the same goes for here. Here it will move more than 100 micrometer again. It also moves especially. So, it is assumed that it can move laterally by almost 200 micrometer. So, ultimately, there is a process where the results of certain movements are offset, but among them, there is no compromise with each other. It's a strong confrontation against each other. Strong versus weak. It's weak versus strong, but this one is strong versus strong. So in the end, problems arise somewhere. He's weak. He has been the victim since we first saw him, and he is the perpetrator, because it is bigger. And since the mandible is denser and bone loss has occurred in the maxilla, we call this periimplantitis. That's how you interpret it. So if the lateral sides become an issue and they protrude like this, if the occlusal plane is not uniform, a premature contact develops laterally, and eventually, if you look at the centric relation, thus, with strong against weak, weak against strong, and strong against strong, it ultimately has a structure that inevitably leads to periimplantitis. I hope you will do a little more in the back and share the occlusal force with each other. Here you can see, this is the premolar, here is the second premolar, and next is a molar. I skipped the end. It's funnier here. Here is the canine. We call the first premolar the number 4, and the second premolar the number 5. However, if you look here, the diameter is 4.5 millimeter. This first molar is referred to as number 6. Diameter 5.5 millimeter. So, the back part doesn't touch, and only this part continues to make contact. Eventually, it is a structure where the bone cannot help but resorb. It's hard to express. There's no other way. Some people argue that bacteria destroy bones. They also conduct bacterial cultures and rush to identify the causative bacteria. However, in my opinion, that may not be due to bacteria, because bacteria cannot develop only in this area. Why doesn't it occur here? Here as well. Why doesn't infection occur? It's the same here. Why doesn't the infection occur? Think about it. If bacteria are the cause, there are no boundaries in the mouth. Everything is interconnected throughout the entire mouth. Therefore, it is difficult to conclude that the bone loss is due to bacteria. In our view, such knowledge seems to be meaningless. However, bacteria are visible while force is invisible. It cannot be confirmed with the naked eye. There's no other way to see the results like this. We need to observe results such as bone resorption, fracture, or loosening. However, if one still tries to find the cause in bacteria, it is difficult to realize the reason. Of course, the bacterial theory is the mainstream opinion, so it's difficult to say much more. When the bone is destroyed, it results in a secondary infection. Then bacteria will form. When you culture bacteria that have been formed in that way, of course you can see the bacteria. Looking at it, it feels like the bacteria have dissolved the bone. We have no choice but to think that way. However, we feel that this is an excessive claim. Anyway, I believe that studying this process well will also be helpful. So you see, there are cases like this as well. You will see now. This is an implant. This is an implant, but there is not much of an overbite. Then space was also created. So these cases make the implants last a long time, because it does not receive occlusal force. In fact, this patient has been using the implanted dental fixture for over 10 years without any issues. And when you fill the space, it widens. So, when you explain to the patient that this side is lifted, and you will also lift this side a bit, the patients are very pleased. It's an obvious issue. So we created space in this way. When you try guiding it, does it barely touch? Here? It almost barely touches. Right working, correct? And then the right side starts working. I'm sorry. It works to the left here. Working to the left and to the right. So the occlusal force barely touches. So it is the same. No matter how you do it, the occlusal force does not make contact, so it lifts a lot. So this ultimately means that the implant is in a structure where it cannot come loose, unless the adjacent teeth or remaining teeth are lost. Other than that, implants have a structure that absolutely cannot come loose. The occlusal surface is like this, so it became a simple implant. Performing implants on the anterior and posterior teeth, in such a case, it's not possible to lift the posterior teeth. The same goes for anterior teeth. You should not consider doing an underbite like this, as anterior guidance needs to be formed. Of course, at the maximum intercuspation position, the anterior becomes an underbite, but otherwise, it cannot become an underbite. So, if you do some research on this as well, you'll find that the same things are repeated. He is a bit older, so he decided to get full mouth implants on the bottom, but since he was very afraid, he only got the anterior teeth done and couldn't do the molars. Also, as you can see, he connected the abutment, did the casting, and then capped it like a conus crown. The reason for this is that if we use an attachment with rubber like an O-ring, it requires constant replacement, so I just started using the metal material, I-bar. Alternatively, we use a metal conus crown like this. This seems to have been the most convenient. I think this was the most satisfying, and I did it this way. If you look inside the mouth, you can see the abutment like this. This is also slightly ground to match the path. Next, as you can see here, we connected the conus and created it this way. So I did it this way and it seems fine. I have been doing it this way for a long time, but recently I do this with a crown. And then the direction has significantly shifted towards implant-assisted partial denture. However, the problem is, when you look at the centric position, there is even contact. The eccentric position is blue. You can see that there is a balancing guide, a working one, and balancing as well. So the focus is not on the implant over denture, but whether a fully balanced occlusion can be created. Next, the maximum occlusal pressure of the dentures should be holding the upper and lower dentures in place. Therefore, it needs to be stabilized. It only works if stabilizing is achieved. If the centric relation occlusion is not aligned in 3 dimensions, then these dentures will slip. Then the mouth cannot be controlled. I've seen quite a lot. If these dentures slide against each other during occlusion, he comes back to the hospital because his gums continue to hurt. So if it's painful here, you trim here. If it's painful there, you trim there. And if you keep trimming, all the denture borders disappear. Such cases are very common. There is currently no grip strength in the upper and lower dentures. When pressed together like this, it should become 3-dimensionally stable and locked. If this moves or if you slip, then he won't put that in his mouth. It's no use trying, and it only leads to conflicts with patients. So I absolutely do not do it. If you put it in your mouth like that, then the centric is firmly set. The centric is clearly established. And when you look at it, it's working. Then the balancing is achieved. This is how balancing is achieved, and it is working. Balancing is captured. So the dentures don't move. This patient is also quite an old patient, and it's been about 10 years since he got dentures, but he continues to use them well. He only comes for checkups, and this patient is quite advanced in age. He is in his late 80s to 90s. There is absolutely no problem, so I don't think there will be any need for further special treatment. You haven't come for about 2 years. I'm curious if you've been well. In any case, it should be ensured that it can be used for a long time without issues. If you look at this picture, it has surpassed the canine. This is called a crossover. So as you can see, it's all referred to as vertical support. You can see that the buccal and lingual touch on the working side. Balancing is involved. This is a very typical picture, and if the dentures are like this, they work well even without implants. As you can see, after the canines, the buccal cusp of the maxilla and the lingual cusp of the mandible provide support, and balancing is also in contact. The lingual cusp of the maxilla and the buccal cusp of the mandible are in contact. This is very common. If it is shaped like this, the denture will not come off no matter where you move. In this situation, no matter where you move, the denture will not come off. It is the same even when moving forward. Even when moving forward, the anterior part was in contact. All molars make contact. You can see this is how we make dentures. Then, no matter where you chew, the dentures remain stable, and there's no way these dentures won't last long. At the very least, even when there is a protrusion, if you completely reveal the jaw, the buccal cusp of the maxilla and the vertical cusp of the mandible are guiding, defining the vertical dimension of the denture. It does not move. This is an important matter. Even doing retrusive or retrusion is the same. If you look at the photo where the jaw is retracted, you will see the lingual cusp of the maxilla and the buccal cusp of the mandible. These are called holding cusps, and they form the retrusive guidance. It's the same. Anteriorly, it forms a three-dimensional space with anterior guidance, posteriorly with retrusive guidance, and includes working balancing. Therefore, the dentures have a three-dimensionally stable structure and receive implant support. Implants contribute not to retention, but horizontal stability and vertical support. The implant support has vertical support. Then the occlusal force increases further. As the occlusal support increases, you will be able to use dentures much better. Therefore, implants should not be the main focus, and you should primarily consider the occlusion of dentures when making them in this manner. If you can't make it like this, I don't think anything we do will be good. Nothing worked, no matter what I did. There are almost no dental technicians who perform this kind of occlusion. That is our problem. We need to learn it and then implement it, but you're trying to do only what's too easy. Currently, in fact, there aren't many dental technicians who are trying to learn about dentures anymore. I have worked in dental laboratory technology for a long time, and because I believe this is correct, we are striving to train a dental technician who can handle such occlusion. We are achieving a certain level of success. So, I think it would be good to consider these things. There is nothing special when looking at the CT scan, and this is a typical case upon observation. If you look, the TMJ there is no disc, and everything is ruined without anything left. In this condition, there is no point in proceeding with prosthetics based on the TMJ criteria. Even if you measure condylar guidance, no conclusions can be drawn. Asymmetric, and the same goes for the much right side. There are hardly any. How this case has turned out now is, this was not done with the condylar prime factor for the prosthesis. If full mouth rehabilitation is performed as a prime factor for dental occlusion, it seems to harmonize well with the condylar. And this denture occlusion protects the TMJ. And because harmony is achieved here, let's take a closer look at the term mutually protected occlusion. The occlusion protects the TMJ, and conversely, since occlusion occurs reflecting the movement of the TMJ, it can be said that the TMJ controls the occlusion. It's such a process, and because of those roles, in some ways it goes beyond the mutually protected occlusion of the anterior and posterior teeth. Overall balance is achieved. Therefore, it can be said that there are principles of mutual protective occlusion. Every time I see several patients, I wonder how much pain the patients must have endured while the TMJ was being deformed like this. The joint wore out completely during this process of disappearing. This means measuring the amount of wear to create a new occlusion. In fact, it's a story that doesn't add up. The logic does not make sense. In the past, a person named Dr. Schultz, the German scholar who devised NAT, came to our hospital and held a seminar for 4 days and 3 nights. He gave a lecture on using that apparatus and computer to measure the condyle and then making a prosthesis based on those measurements. At one time, this was called the occlusal compass. He is a person who became internationally renowned for the occlusal compass theory, Dr. Schultz. You may think so, but to perform full-mouth prosthetics with pathologic data means it is illogical. Using pathologic data, occlusal splints or TMJ treatments are conducted. That's not correct. So it seems that these things are not measured much these days. Useful for diagnosis, but because it cannot be used for treatment, it is only used for measuring length. To say that treatment will be done with this data, it doesn't make sense, does it? So most of these claims have disappeared. And if possible, we must find a way for the occlusion to protect the TMJ. Earlier, as mentioned, maintaining occlusal space with 3-dimensional grip force or the movement of the jaw is stabilized by the guidance of the teeth. Meanwhile, TMJ and each achieve balance with each other. These concepts have become more important. As before, measuring the TMJ as a prime factor. Using that data perform the restoration. I think this kind of concept has largely disappeared. I am having this thought right now. So this is the situation. Another patient, but he has also been receiving treatment for quite some time. So as of now, it's all on X. All on X, but in the past it was called a fully bone-anchored prosthesis. There is a prosthesis. About 30 years ago, to the brain-mark implant, there was a book that introduced a lot of these new technologies. Brain-mark implant. So when he introduced such new technologies, there was also something like this. At that time, there was an abutment called aesthetic cone. We now call it a multi-unit abutment. I use this a lot to replicate prosthetics. So this is done by titanium casting. It's about the multi-unit abutment, all on X to all on 10. These days, there is also all on 6. There is also all on 8. In the brain-mark implant, all on 6 was initially developed. However, I felt uneasy because the back was broken. The frame of this prosthesis kept breaking. Therefore, it is now recommended to perform all on X if possible. Also, in most cases, the 7th tooth is not restored. So it became all on 8. And if they cannot be implanted at the back, it becomes all on 6. The fully bone-anchored prosthesis done with all on 6. Recently, it is often advertised as all on X. It seems that there are some individuals who gain significant economic benefits from that technology. So he considers that technique special. It is a technology that has existed for a long time. The reason multi-unit abutments are sold a lot overseas is because of that, but it doesn't work well in Korea. Because the occlusal force is strong, it cannot withstand well. So there is something called all on X, and these days there is also the magic 4 concept, which involves placing only 4. I cannot understand. If the opposing teeth are denture, it is possible, but it doesn't matter if you implant 6 or 8. I don't think that will work. It seems like you have failed a lot. So there are a few people who are suffering. There are many, not just 1 or 2. In the past, a person did it by implanting 8 on the upper part, and they all fell out. The patient probably received treatment at the university hospital at that time. It seems he was given about 40 to 50 million won treatment course. After that, everything fell apart, so I remember we had a lawsuit for quite a long time. So it was a bit difficult. Anyway, the concept of all on X is not something that recently emerged. It has been around for a long time, and it started with brain-mark implants. A certain dentist from Spain popularized this worldwide, and suddenly he entered Korea, which seems a bit amusing to us. Anyway, if the dentures are the full set, how does this occlusion work? In the case of a fully bone-anchored prosthesis, fully balanced occlusion must be maintained. As far as I know, he is an acupuncturist. I treated him by implanting 10. There was a dental clinic in the same building as that patient's hospital, and the dentist there spoke very badly about me. So he came and got angry. Other places say that only 6 are needed, so why did you plant 10? Isn't this excessive treatment? He complained like that. I remember that he was the uncle of the director I was in partnership with. However, he says he is still using it well. It seems to be around 15 years old. It's been almost 15 years. We continued follow-up and management and maintained it for about 15 years. I also got a lot of criticism at that time. He is satisfied now, but at that time it was difficult. So I don't understand why he says it can be treated by placing only 6 implants. There are also such patients. If you look here, the molar area is missing. Then should we extract 1 or 2 teeth and do a bridge? If we remove one here too, it will become the magic 4 concept. What about the anterior teeth? So everyone is doing something that doesn't make sense. Therefore, placing implants in the maxilla is troublesome. You may perform a bone graft first and then proceed with the treatment, but the bone is almost non-existent. It won't last that long. This patient has also been using it well so far. All on X makes no sense. The TMJ is healthy. So it's okay. The prosthesis has been removed, and then the maxilla is restored with a full denture, while the mandible is constructed with a fixed bridge. It fits perfectly once you put it in your mouth. Centric contact and eccentric. So it seems he's been doing this for about 15 years as well. I am using it well without any problems. I have been practicing dentistry in one place for over 30 years. So, if this treatment becomes problematic, it could be a serious issue. It was captured up to retrusive. So you like it a lot. In the end, do you bring the teeth into contact or separate them? This is quite an important issue for us. Simultaneously bring them into contact or issues of that nature. Next, instead of causing any disturbance, contact both the left and right sides together. If the anterior guidance discludes the posterior, mutually protected occlusion causes one side to disclude and the other side to contact. These situations are exactly what occlusion is. So I think this needs to be studied further. We will conclude here for today. In the next session, I would like to discuss centric occlusion contacts in more detail and present some practical methods. So in the end, if you consider it, do you make contact or make it isolated? How much should the amount be? How much contact should be made? These are the kinds of stories, almost all of them. Let's think about that a little more. I believe that making wise decisions will lead to good treatment. I will stop here for today. Thank you.